Welcome to Deep Dive Ortho, the deep dive into the insights you need to stay sharp and well informed. Today, we're tackling anterior interosseous nerve syndrome, AIN syndrome. Now, it's a condition that, while rare, can be a real diagnostic head-scratcher for us orthopedic professionals. Its pure motor presentation really sets it apart, and our understanding of its origins has evolved quite a bit. I'm joined by Prof. Mo Imam, who will help us unpack the nuances of this fascinating condition. Okay, let's dive in. So let's start by laying the groundwork. How would you define AIN syndrome for our orthopedic colleagues, and what's that immediate clinical signature we should be looking for?
Well, AIN syndrome is quite a specific type of forearm compressive neuropathy. What makes it so distinct and sometimes challenging is its purely motor deficit, no sensory loss at all.
Purely motor, right.
Exactly. You see weakness, specifically in the flexion of the thumb, index, and middle fingers. This affects the flexor pollicis longus, the FPL, the index and middle finger parts of the flexor digitorum profundus, FDP, and the pronator quadratus,
The
PQ.
classic sign.
Ah, yes. The hallmark clinical sign, often called the Kilo-Nevin sign, is the patient's inability to make a proper OK sign. Instead, you might see their thumb and index finger sort of flattening together.
Okay.
It's genuinely rare, mind you. Makes up less than 1% of all median nerve neuropathies, which, speaks to why it can be missed sometimes.
That pure motor aspect, then, the complete absence of any sensory involvement that sounds like a critical diagnostic filter right from the start, how much does that help narrow things down immediately in clinic?
Oh, it's absolutely crucial. That pure motor presentation is the primary red flag, really. It immediately steers us away from many other conditions that would present with sensory changes.
Like carpal tunnel or pronator syndrome, for
It's
instance.
precisely. It's what makes us think AIN syndrome or perhaps a variant of it right from the outset.
Now, it sounds like for many years, the orthopedic community viewed AIN syndrome through a fairly specific lens, mostly thinking about compression. But our understanding of its origins, well, it seems to have evolved significantly, hasn't it?
It really has. The why of AIN syndrome has been quite a journey.
What were the prevailing theories initially?
Traditionally, yes, it was almost exclusively considered a compressive neuropathy. The idea was something was physically pressing on the nerve. And we did, and still do, identify common entrapment points.
Such as?
The tendinous edge of the deep head of the pronator teres is probably the most frequently cited. But other potential anatomical culprits include the fibrous arch of the FDS, or even accessory muscles like Ganser's muscle, that's an extra head of the FPL, or sometimes aberrant arteries.
Okay, so the mechanical view.
Yes. However, the really significant shift in our understanding, and I think this is a game changer for clinicians, is the strong evidence now suggesting that AIN syndrome is often actually a variation of neuralgic amyotrophy.
Neuralgic amyotrophy, so an inflammatory picture.
Exactly. It's an idiopathic, immune-mediated neuritis. For you in practice, this means looking beyond just a mechanical pinch. Patients with this neuritic origin often report a very acute prodrome, intense upper extremity pain, usually kicking off in the shoulder, arm, or elbow before the motor palsy sets in.
Right, that prodrome is key.
It is, and electrodiagnostic studies in these cases frequently show a more diffuse pattern of peripheral motor nerve axonopathy, not just a focal compression you'd expect from a simple pinch.
I see.
And quite compellingly, histological biopsies from some AIN syndrome patients have even revealed inflammatory markers, things like CD8 plus T lymphocytes, fibrosis, and edema, which strongly supports an inflammatory immune-related cause over pure mechanics.
That's a profound shift, isn't it? Moving from thinking purely mechanical issue to potentially an immune-mediated one. For our listeners, how does this fundamentally change their diagnostic approach, or maybe the questions they should be asking when taking a history?
It's a critical change in perspective. Instead of just asking about, say, repetitive strain or recent trauma, you're now probing specifically for that sudden severe pain onset, especially in the shoulder or arm that came before the weakness.
Looking for that sequence.
Precisely. You're thinking about recent viral illnesses, perhaps, or other systemic inflammatory triggers. It really expands your differential diagnosis beyond just local compression.
So it brings other conditions into the frame?
Yes, it means considering things like Parsonage-Turner syndrome, that's a viral brachial neuritis, which can also present with AIN-like signs, sometimes even bilaterally, often following a viral illness and that characteristic intense shoulder pain.
And how do you then differentiate the let's say, true AIN from other things that might just look like it? I'm thinking simple external compression, maybe from a tight cast or even a splint. That must be a common pitfall.
It is, absolutely.
Yeah.
While external compression from, say, a supracandicular fracture, maybe crutches, or tight dressing can certainly mimic AIN syndrome, these aren't typically considered true AIN syndrome.
Because the cause is different.
Exactly. Their underlying pathophysiology is different, and critically, the symptoms usually resolve once you remove that external pressure.
Yeah.
So it's about looking at the full clinical picture. We also need to be aware of anatomical variation.
Ah, yes, like the Martin-Gruber connection.
Precisely. The Martin-Gruber anastomosis, where some median nerve fibers cross over to join the ulnar nerve. That's found in about 15% of the population, give or take.
And that complicates things how?
Well, it can lead to intrinsic hand muscle weakness in addition to the characteristic AIN deficits, which can certainly muddy the diagnostic waters and make the clinical assessment more challenging.
Okay, so with all these nuances, the potential inflammatory cause, the mimics, the anatomical variations, what's your clinical playbook for confidently diagnosing AN syndrome, especially for someone perhaps seeing this for the first time in their practice?
Well, the diagnosis primarily hinges on two things: a meticulous patient history, really digging into the onset and nature of symptoms, and a very thorough physical examination. These are then supported by targeted electrodiagnostic studies.
And clinically, what are the absolute must checks?
Clinically, as we've discussed, that inability to make the OK sign, specifically due to weakness in the FPL, the FDP of the index and middle fingers, and the PQ, that's paramount. And crucially, you're actively looking for completely normal sensation. That's critical for differentiation.
Normal sensation. Got it.
Weakness in forearm pronation with the elbow maximally flexed can also be assessed, though, or its diagnostic value is still a bit debated in the literature.
Okay. And then investigations.
From an investigative standpoint, electromyography, EMG, is truly the preferred diagnostic modality. It typically reveals abnormal activity fibrillation potentials, positive sharp waves, and prolonged latency periods within the evoked action potentials of those specific muscles we mentioned: the FPL, FTP, index, middle, and PQ.
EMG sounds absolutely critical here then. Can you walk us through how it specifically helps you triangulate on AIN syndrome and, importantly, rule out those mimics that might, well, keep us up at night thinking about other possibilities?
EMG is invaluable because it allows us to precisely localize the lesion. It helps rule out more proximal issues, things like cervical spine pathology or a brachial plexopathy, which might present with arm weakness but would have different patterns.
Right.
And crucially, it differentiates AIN syndrome from conditions like pronator syndrome or carpal tunnel syndrome, which, as you know, fundamentally involves sensory changes. The EMG would show those sensory nerve conduction study abnormalities, which are absent in pure AI.
And you mentioned serial EMGs.
Yes, serial EMGs can also be incredibly useful for monitoring a patient's functional improvement over time. Seeing reinnervation potentials can be very encouraging.
What about imaging? MRI or ultrasound?
Well, magnetic resonance imaging, MRI, isn't routinely used for diagnosis in every case, but it can sometimes offer early diagnostic insight. Occasionally, it might reveal increased signal intensity or edema in the distribution of the AIN, particularly within the pronator quadratus muscle. Ultrasound can visualize the nerve, but its clinical utility is somewhat limited due to the nerve's relatively small size and deflocation.
So less reliable, perhaps.
Often less definitive than EMG, yes. Ultimately, it's a combination. A comprehensive clinical assessment, including detailed strength testing, maybe using the MRC scale, and perhaps a disability of the arm, shoulder, and hand, or DSH score to quantify the functional impact. This, combined with those definitive electrodiagnostic findings, forms the bedrock of our diagnosis.
And you'd also confirm negative provocative tests.
Absolutely. You'd expect negative Tinel's test at the wrist and elbow and a negative Phelan's maneuver, which again helps rule out other more common median nerve palsies like carpal tunnel.
Okay, so we've worked through the complexities, we've got the diagnosis. Now, what's the typical journey for a patient from here? Do we jump straight to interventions, or is there a primary approach you'd advocate?
For most patients, conservative management is generally the first-line approach. This is largely because AIN syndrome often proves to be a self-limiting condition, especially those potentially linked to neuralgic amyotrophy.
So watchful waiting and support?
Essentially, yes. This typically involves rest, modifying activities that might aggravate symptoms, and sometimes splinting the elbow, often near 90 degrees of flexure, or simply in the position the patient finds most comfortable.
And managing symptoms.
Symptomatic relief is provided with simple analgesics or perhaps non-steroidal anti-inflammatory drugs if needed. Physical therapy is also a key component.
What does that involve?
Usually things like massage, gentle forearm stretches, and specific nerve gliding exercises. The main aims there are to prevent contractures and maintain range of motion while the nerve recovers. We've also seen some clinical reports mentioning the use of electrical stimulation therapy and sometimes supplemental vitamin B12, though the evidence for those is perhaps less robust.
That sounds promising for many patients then, this conservative route. What's the typical timeline our listeners should be setting expectations for, both for themselves and their patients? And are there any predictors for a better or indeed a worse outcome with conservative care?
Well, clinical experience and quite a bit of research strongly suggest that the majority of patients will improve with non-operative management. Symptom resolution usually begins somewhere between 3 to 12 months from the onset of symptoms.
3 to 12 months to start seeing improvement.
Yes, and full recovery often takes longer, perhaps up to 18 months. We usually quote a mean recovery time of around 9 months. Interestingly, some studies have even reported no significant difference in recovery time when comparing conservative management to immediate surgical intervention, which really does support trying the non-operative approach first in many cases.
Any factors influencing recovery speed?
Younger patients, particularly those under 40 years old, do tend to experience faster recovery rates. That's a fairly consistent finding. However, it's crucial to counsel patients that recovery can sometimes be incomplete. Residual weakness is not uncommon.
Particularly in the neuritic cases.
Yes, especially in cases clearly linked to neuralgic amyotrophy. Some studies show over 60% of those patients having some degree of residual weakness even 3 years after onset. So, managing expectations is important.
Right. So if conservative care doesn't quite get the patient where they need to be, or perhaps if there was a clear mechanical culprit identified right from the outset, when do you start seriously considering surgery, and what are those key triggers?
Surgical decompression is typically considered under a couple of main circumstances. Firstly, if there's a definite space-occupying mass identified on imaging like a tumor or maybe an aberrant muscle clearly compressing the nerve.
That seems straightforward.
It is. The other main indication is if non-operative treatment fails to yield significant clinical improvement after a prolonged period.
And how long is prolonged?
Well, that's often debated, but generally we're talking after 6 to 12 months of consistent, appropriate conservative management with no meaningful progress seen either clinically or perhaps on repeat EMG. The optimal timing for surgery, though, remains a subject of discussion.
Especially for younger patients.
Exactly, especially for patients under 40, as many in this age group, as we said, are noted to respond well eventually to non-operative management, even if it takes time. You don't want to operate unnecessarily.
Makes sense. And if surgery is indicated, what's the success rate like?
When a clear compressive cause is identified and addressed, surgical success rates are generally reported to be around 75%, sometimes higher.
And the procedure itself?
The standard surgical technique usually involves what we call a lazy S incision over the proximal volar forearm. This allows good visualization of the AIN and enables release of all potential entrapment sites, the superficial head of the pronator teres, the lacertus fibrosus, the superficial arch of the FDS, and any accessory muscles like Ganser's muscle if present.
And post-op?
Early motion is typically encouraged post-operatively to prevent adhesions. Minimal incision surgeries like endoscopic decompression have also been explored.
Any difference in outcomes there?
Current evidence suggests no significant difference in outcomes compared to the traditional wide incision surgery, but perhaps with potentially quicker early recovery for some.
Okay. Now, in those very rare, challenging cases where function isn't fully restored, even after appropriate conservative management and perhaps even after surgical decompression, what then? Are there further options, and how often does that scenario actually arise?
Thankfully, such cases are indeed rare. We're talking maybe only 5 to 10 cases reported in the literature, where a persistent, significant motor deficit necessitates further intervention beyond decompression. It's uncommon.
But if it does happen?
In those instances, tendon transfers can be considered to try and restore some function. For example, transferring the brachioradialis tendon to the FPL tendon might be performed to regain some thumb flexion.
And how effective are those?
Well, the literature described the overall efficacy of these tendon transfer procedures as somewhat unimpressive, unfortunately. They can provide some benefit, but often don't fully restore normal function.
So it's really a salvage procedure.
Very much so. And given the possibility of late spontaneous recovery, even after a long period, a prolonged observation period of at least 1 year, continuing with therapy, is generally recommended before even considering such interventions. It really is a last resort.
That was an incredibly insightful deep dive into AIN syndrome. It's really clear that while mechanical compression was, historically the primary focus, the compelling evidence now linking it to an idiopathic immune-mediated neuritis fundamentally reshapes our diagnostic approach and our management decisions. The diagnosis really hinges on that careful clinical exam, looking for that pure motor deficit, that okay sign issue, supported crucially by electrodiagnostic studies, and then understanding when to stick with conservative care versus when to consider surgical intervention seems absolutely key.
Absolutely. I think what this truly highlights is the dynamic nature of our understanding in orthopedics. For clinicians listening, it really means always keeping an open mind, looking beyond the perhaps obvious mechanical explanation, and integrating newer evidence about inflammatory causes to provide the most precise and appropriate care.
It's a powerful reminder, isn't it? That even in seemingly quite specific or rare conditions, there's always potentially a deeper layer to uncover.
Precisely. It pushes us to consider a broader clinical picture.
A powerful reminder indeed to always keep digging deeper. If you found this deep dive valuable today, please do take a moment to rate and share the show with your colleagues. Thank you so much for joining us and sharing your expertise.
My pleasure. Thank you for having me.
And thank you all for listening to Deep Dive Ortho. We'll be back soon with more essential orthopedic insights.